Neurogenic bladder. The bladder is innervated by the parasympathetic nerve from the sacral 2, 3, 4, coming by the pelvic splanchnic nerve, and sympathetic thoracic 12, lumbar 1, 2. So, but predominantly bladder is controlled by the sympathetic parasympathetic fibers, and there is your cortical inhibition, cortical facilitation, and pontine micturition center. In these few places, you have local micturition centers in the spinal cord, onus, nucleus. Well, these are the apparatus that control the bladder activity in coordinated fashion. That's why when bladder contracts, urine passes, the spindle relaxes. And when it doesn't occur, as it is in the meningocele in 80% of cases, and other lesions like T-that cord syndrome, lipomeningocele, sacral agenesis, diastomalacia, and few more spinal cord lesions like trauma, tumor, transverse myelitis, brain infection, cerebral palsy, and your pelvic surgery causing the nerve damage is also possible. Irradiation, non-neurogenic, neurogenic bladder, Hinman bladder. These are the causes of the your neurogenic bladder. And how do they present? They present with the high bladder pressure, more than 40 centimeter water, and they have lower urinary tract symptoms like incontinence, nocturia, nocturnal anorexia, and urgency, daytime frequency, body storage symptoms like hesitancy, staccato pattern, dribbling, and your retention, and so forth. So this back pressure causes security by damaging the upper tract kidney. So diagnosis of these cases is by your uroflowmetry and urodynamic study. It can be video urodynamic study with electromyography of the bladder muscles and sphincters. So normally the uroflowmetry curve is bell shaped, but when it is plateaued, and now you have obstructive features, when there is intermittent sort of urine flow into as occurs in dysfunctional body, staccato pattern, now you have this sort of your curve in the uroflowmetry. So you need to do at times the MAG, the MAC3 or DTPA to know the differential function of two kidney, and DMSR tells you the scar and the function also. Creatinine biomarkers and then infection markers have to be checked. Treatment of those cases mostly CIC, the 4 to 5 times a day, maybe in overnight indwelling, and and irrigation over distance in the bladder at times useful, and intravesical the oxybutynin and antiseptics like chlorhexidine 2% and then gentamicin. Anticholinergics at times you can try with your sulfasalazine and your oxybutynin and etc. Finally, good amount of patients progress to CKD. They need dialysis. Transplant here is too difficult, but to go to the transplant, you must be sure that bladder pressure is normal below 40 centimeter water. Thereby, at times you need to go for an diversion like mitrophanol and others, ileal conduit and others. When bladder pressure is normal, you can go for transplant in those cases. So. Care of bowel, laxatives, and others, and lifelong care of these cases. And Arnold tear malformation when there is spinal dystrophy, the meningocele, the brain malformations, they are also to be looked upon and addressed as such.